Okay, today we have Professor Cathy Balding to address a number of issues in relation to clinical governance. So you just provided a lecture to our students. How are you feeling?
Yes. Okay, Ming. All right.
And it's just
I think it went all right. You'll have to ask the students.
That's good. Yes. So I will ask you probably around 3 questions. Mm-hmm. And the first question is, there's a number of healthcare scandals between late 1980s and early 2000s led to the efforts in improving the quality and safety of healthcare service provision in the system level. And however, after more than a decade of efforts, we still see scandals rocking our healthcare system, like this recent St Vincent Hospital scandal in New South Wales. Just an example. So in your opinion, why the goals of substantially improving quality and safety of health service provision are so difficult to achieve, and why has progress been relatively slow?
Okay, well, thanks, Ming. That's a tricky one to start with, but it's all tricky. All of this is difficult. I think you said, why haven't the goals been achieved? Well, I think part of the problem is we don't have specific goals. We have some goals from the Australian Safety and Quality Commission, although at the moment they're not universally pursued. That may change over time. They're relatively new. But in terms of overarching shared goals for the safety and quality of care we want to provide across the healthcare system, there really aren't any. And I think that is part of the problem, because without a shared view of what we're trying to achieve, it's very difficult to do the thinking and the research and the testing and the implementation to find out what really works to achieve those goals. So in the absence of goals for providing great care for every person every time, which I think should be a goal, we tend to implement various system components and almost hope that that makes a difference at point of care. And within the complexity of healthcare, that's not quite enough, because within a complex system like the health system, you have to be crystal clear about what you're trying to achieve to be able to navigate the complexity to get there. So I think we get a bit stuck within that complexity. So we try different things at different times. Some things work, some things don't, but we're not on a clear, consistent pathway. So we're using clinical governance in a lot of different ways rather than as a means to an end. The end should be great care for every person every time, and some really specific definitions and goals around that. And then we should look at our clinical governance systems and say, okay, how can they help us to get there? But in the absence of the goals, you end up with clinical governance systems being an end in themselves rather than a means to that end. And I think that is definitely a big part of the problem.
You just mentioned that when implementing any changes to achieve the non-existing goals, some works, some don't. Do you think our system really know what works and what don't when we actually can measure a lot of quality domains that we think is important?
Yes, it's a really good question. I think we're grappling with that. We're very much in transition, I think, between not thinking we need clinical governance and knowing that we do, but not quite sure what the right combination of factors is. Some clinical governance systems are evidence-based, so if we look at things like the impact of training or how important open disclosure is, for example, when we harm a patient and talking to them and apologising. We know how powerful that is, and there's good research around that. And there are other things that we just do because it sounds like a good thing to do and we should do it, but we don't really know the impact. So that is definitely a problem. We're in a learning phase, definitely, and I hope in 10 years we'll be a lot clearer on the levers, the clinical governance levers that we know work. I think the other thing too is we've got a big mindset change to make, and this is really, really tough. We've come from a set of beliefs around healthcare and the people who work in healthcare, which is they are expert at what they do, they are incredibly well-intentioned, and they work very hard, all of which is true. But we relied solely on that for centuries, really, to provide good care, without recognising or understanding that even the best person is still human and will make mistakes and have bad days. And so we need more than just that reliance on great people doing a great job to achieve consistently safe, high quality care. And I think that mindset change, like all mindset changes, is quite slow. It's happening, but that sort of thing doesn't happen overnight. It's almost generational change, I think. And so, you know, those things make it really difficult for clinical governance to have the impact it should, because there's still a lot of people out there who wonder why we need it in the first place. So we're not quite there yet with that change of mindset.
Sorry, I still keep dragging into this topic.
Yeah.
You mentioned the errors the human made. I think 20 years ago they already recognized human errors is not the problems of quality safety, but there's no system processes to prevent human errors. Do you think this is still the case, that we're not doing that to prevent that happening?
Well, I've seen a lot of good changes when it comes to putting systems in place to prevent error. And I think particularly in Australia, in the areas covered by the 10 National Safety and Quality Standards. I have seen that make a significant difference because they're mandatory standards. You have to pass them for accreditation, and if you're not accredited, there's a whole series of processes that you need to go through if you want to stay viable as a health service. So it, you know, there's a lot at stake now around accreditation, and particularly the clinical areas covered by those national standards. I think that we've made significant advances in those areas, such as blood management and infection control, because those standards tell you the systems that must be in place, and they're not negotiable. So people have had to step up and raise the bar around those key risk areas and improve those clinical systems so that patients are not harmed in those areas. And some data now, although it's slow, like all things when it comes to healthcare, some data now are indicating significant gains in some of the areas covered by the standards. So I think that where you do see systems put in place in a systematic way, where it's mandatory, not negotiable, I think it does make a big difference to care. But there's many, many things that we do in healthcare that are not covered by mandatory standards, and I think that's part of the problem too. So it can become a bit discretionary depending on what health service you're in or who's treating you as to the rigour of the systems they have in place.
Well, since you already mentioned clinical governance, which is related to the second question,
Yes.
So could you just elaborate a bit what clinical governance means, and what's the major advances that made in clinical governance to how in healthcare organisations or healthcare system overall?
Yes. Well, there are many definitions of clinical governance, so I usually tell people to use the one that they understand best and that speaks to them in their environment. To me, I think clinical governance is essentially about accountability. And it really was born of initially those first public inquiries into poor care that demonstrated that in healthcare we weren't great at rigorous accountability for what happens at point of care, that there tended to be a bit of a separation between what the clinicians did and what the managers did, and then perhaps what the board was looking at. And clinical governance says that right from the top of the organisation, whether that's a corporate office or a board, that they are ultimately accountable for the services provided by the organisation and the quality of those services and the outcomes achieved by those services. And that has made a big difference. Certainly we're still grappling with it because it is a big change, and it's part of that mindset change, because originally boards of health services were involved in the business of the health service, managing the finances and the fundraising, and then later setting the strategic direction. All fantastic things and still very important. But the clinical care, that was someone else's issue. That was the doctor's issue or the nurse's issue. So some boards still struggle with this a little. Where have we made, real advances with it? I think just the understanding of the importance of that accountability, that is a big advance because it's a big change. And understanding now, any board that I speak to, even if they're struggling with the how, they do understand that fundamentally they are accountable for what happens at point of care. And that alone makes a big difference because it changes the conversation that they have with their executive, and it changes the way that their executive has to think about how they lead right through the organisation, down through line management, how they delegate, how they support staff, and then how they hold them accountable.
So is this a common model have been applied to majority health services in Australia now?
Yes, you would absolutely find that in most. I would never say all because you never know. But in most health services you would see whatever the governing body is, having that understanding that they are responsible for what happens at point of care. A lot of people think that clinical governance is the systems, is the consumer participation system and the risk management system and the improvement system and the credentialing system, and they are all incredibly important. But once again, they're a means to an end. They're a means to supporting those staff to enact their accountability, their personal accountability for what happens at point of care. So if you just have those systems in place and don't carefully apply them to what the staff are doing every day and see them as supporting systems, they will just be extra things that people have to do. And this is where clinical governance goes off the rails, I think, when it becomes extra tasks rather than a series of systems that are designed to support staff to do a great job and to help them to do a great job and to be accountable for the jobs that they do.
So relate back to the first question I asked you, that it is so difficult to substantially improve the quality and safety in healthcare organisation on the system, and the progress has been very slow. So what are the current gaps that you think we need to address? And what significant improvements do you think we need to make now across the system?
Yes, I think about this quite a lot because this is what I do really every day. And the gaps that I see are still gaps in fundamental understanding. If I could do anything, I would probably wave a wand and change the way people think about this, because that would make a big difference. I still think we haven't really grasped in healthcare that we are a complex system. Too often I see quality and safety pursued in health services as if it's a factory. Oh well, we'll just put a whole lot of things in place, and here's the standards, and here's the audit system, and here's the reporting to the board, and here's the training, and everything must be great because we've got those things. And in an ideal, perfect world, that would work, but that's not how complex systems work. So it's not how our healthcare organisations work, which are complex systems. They are much more like the road system, where there's a great variety of factors that dictate how well the traffic flows, and that changes every day. It's a dynamic system. It doesn't stay static for very long at all. And so if you don't think like that and address safety and quality within that context, you're not going to make very much progress. You're not, just by having things in place, you're not going to have the impact that you need to have. You need to think about your organisation as a dynamic, complex organism and understand the levers that it takes to create safety and quality within that complex environment. And I think we haven't quite grasped that yet in healthcare. I see an awful lot of mechanistic approaches to creating safety and quality of care that don't have very much impact. A lot of goodwill, a lot of hard work, a lot of great tools, a lot of amazing initiatives and projects, and occasionally, externally funded, which do make a difference to some consumers, absolutely. But getting that overall, everyone working towards every patient, every time, having great care, that takes a deeper understanding of how our organisations actually work. And I don't think we're there yet.
So who should lead the process? So you said you need to understand. Yes. So who will be those you?
Yes, yes. Well, this conversation is about the system, isn't it? And so I would love to see departments of health, for example, show more leadership in this area. I would love to see them further develop their deep understanding of how to create safety and quality in a complex system, and then hold their health services to account for that as well. So whether or not, and every health service, every health system, every jurisdictional health system has a different approach. So how New South Wales would do it versus Queensland versus Victoria, all different, because to have them all the same would be too easy. But in Victoria, say, where we have quite a decentralised model, for the department to think about, well, what is our role in providing providing the information, the education, the training and the support for health services to develop this understanding, so that we get to a point where perhaps when we're interviewing for new CEOs, we expect them to have a good knowledge of finance, and we expect them to have a good knowledge of how to create a good product in their service, which is essentially the role of any CEO in any industry. But I think in healthcare we haven't really expected that of CEOs. As long as they can manage the money, everything else will kind of take care of itself. Of course I'm generalising, but I would like to see that question around how do you create high quality safe care for every person within a difficult, complex environment to have the same weight as how do you manage the finances within a constrained and very difficult economic environment. When those two have equal weight, I think we'll be getting there, because once the CEOs get it, everything else will flow from there.
I think at the end of the lecture, you made a remark, I think really inspiring to a student. You said the best tool in improving quality and safety is
staff. People.
Yeah, people.
Yes.
So it means our students actually can make a difference.
Yes.
To the health system.
Yes, and I firmly believe that. It took me a long time, Ming, to come to that conclusion, because when you start out in safety and quality, and I think a lot of people get a bit stuck in right in this space, it's all about the tools. You're worried about what you're measuring. You're worried about whether your staff are using the Plan, Do, Study, Act cycle. You're worried about your incident reporting and your risk management. And once again, all incredibly important tools, they are. But unless your people, right from the top of the organisation, right through management, right to point of care, unless your people understand what their role is in providing safe care, feel supported to enact it, have the tools to do it, it doesn't matter how many quality and safety tools you throw around. If those people aren't engaged in the process, and I've seen it a million times, you can expend an awful lot of effort trying to implement those tools with very, very little impact. And I just don't think we've got time for that anymore. I think, helping people to understand their role and working with them, because people generally want to come to work in healthcare and do amazing things for their consumers. It's tapping into that and helping them to enact that role, and then giving them the great tools to help them do it.
Well, thank you very much, Cathy, for sharing your insights and your expertise. And we're going to come back for the second interview, focus on clinical governance in health services or healthcare organisation level.
Yes, fantastic. Thanks, Ming.
Thank you.